Okay, let's proceed with the presentation.
Okay, my name is Muhammad Nabil. I'll be presenting about neonatal thrombocytopenia. So, thrombocytopenia means that the platelet count is below the normal range. So, as for the normal range, it is around 150 times 10 power of 3. Power of 3. Okay, to 450. This it's also shown that we can categorize thrombocytopenia into mild, moderate, and severe. These are the number for mild, moderate, and severe. As severe, it shows that below counts of 5, 10 times 10 time 1000 MCL. So next slide. So basically, platelets is derivative from the megakaryocyte, which is the production is influenced by the thrombopoietin. So when patient has thrombocytopenia, what we fear in neonate with thrombocytopenia is we fear of the complication intracranial hemorrhage, which has high mortality and morbidity. Next. So these are the etiologies for neonatal thrombocytopenia. It can be categorized into 3 parts. Actually, there are other how we want to categorize it. The common one is the early onset and late onset of thrombocytopenia. So for this categorization, I divided into increased destruction, decrease in disease, and miscellaneous. So destruction divided into subcategorization: immune mediated, sequestration and trapping, platelet activation, and consumption. So I'll be explain later about the neonatal autoimmune thrombocytopenia and neonatal autoimmune thrombocytopenia. So next. So from history, we need to ask whether the patient has thrombocytopenia early onset or late onset of thrombocytopenia. And then we need to ask a patient the baby term or preterm, because patient that is preterm has higher risk of having thrombocytopenia. And also maternal history is also important, like autoimmune disease like systemic lupus erythematosus, which can contribute to neonatal autoimmune thrombocytopenia. And also, we need to ask the viral infection, then mother have affected by STD, taking the medication, toxopenia, previous pregnancy with low platelet child, children of dying of hemorrhage. Need because if the mother have infection or STD, can lead patient to has TORCHE, torches, which also can lead to sepsis and platelet consumption and coagulopathy.
Sorry.
Presenter, what is torches? What is torches?
It's a group of the viral infection, like saya lupa, sorry.
This is the problem.
Toxoplasmosis, rubella, cytomegalovirus, and herpes simplex.
Yep.
And agent for others.
Herpes simplex. So toxoplasma,
yes.
which is toxoplasma gondii, and then rubella, cytomegalovirus, herpes simplex. Okay, that's torches. Okay, all right. It's very common. All these torches are very common causes for neonatal infection, congenital infection. There's so many problems with it. Okay, all right, proceed.
Next. So in physical examination, we must look child general well-being. The patient is ill-looking or well-looking. So this is other categorization in neonatal thrombocytopenia. The we look patient is ill or not ill. Is there any evidence of bleeding like mucosa punya mucosa punya hemorrhage, patopetike, any bruise, or we look for organomegaly, hepatosplenomegaly, or we look any syndromic features like patient with thrombocytopenia absent radius or TAR. We can see that patient has a bilateral absence of radius. Also, we look about Wiskott-Edwards syndrome. Basically, Wiskott-Edwards syndrome is a rare condition. It's a X-linked recessive disease. But Wiskott-Edwards syndrome is a triad syndrome, which consists of eczema, severe immunodeficiency, when a patient has a recurrent fever or infection, and also patient has thrombocytopenia, and also Fanconi anemia. So Fanconi anemia is also a genetic disorder. It is predominantly autosomal recessive disorder, but very small percentage is X-linked recessive in manner. So patient with Fanconi anemia just not presented with anemia, they also can present with pancytopenia, which also can lead to thrombocytopenia. The other sign of Fanconi anemia, short stature, microcephaly, microphthalmia, hypo or hyperpigmentation, and abnormal tongue. But this sign is not specific to Fanconi punya syndrome. Next. So what we want to look in physical examination in mucosal bleed, ini present of petike or purpura, present of organomegaly, microcephaly, and patient with Fanconi can present with radial and thumb defect in Fanconi syndrome, and also look of absence of radius. So patient with torch infection can have a sign like blue muffin spot, and hemangioma in Kasabach-Merritt syndrome, which is Kasabach-Merritt syndrome ni is a formation of hemangioma with thrombocytopenia. The disease has consist of constellation of vascular lesion, thrombocytopenia, consumptive coagulopathy, and microangiopathic hemolytic anemia. Next. So this is the commonly used to categorize thrombocytopenia in neonates, divided into ill appearing or well ill appear, or the baby well, and also we divide it into early or late onset for both category. Next. So I want to explain about neonatal alloimmune thrombocytopenia. So what we understand from alloimmune is the antibody from the other organisms, other source. It is destruction of neonatal platelet due to maternal antibodies. So the pathophysiology is that is when the neonates punya platelet antigen is inherited from the father. So the antigen makeup of the baby is from the father, and the mother antibody IgG recognize it as foreign and destroy it. So the diagnosis is made from the presence of maternal antibody binds to the paternal platelets, and some specific human antigen incompatible between mother and father. So basically, the management for thrombocytopenia will be there is a algorithm that I'll show you later. So basically, patient thrombocytopenia, we either monitor, or if severe enough, we need to do platelet transfusion. Next. So this is neonatal autoimmune thrombocytopenia. It is caused by the maternal autoantibody targeting both maternal and fetal platelet. In this case, it's not just the baby has platelet thrombocytopenia, but also mother also can have thrombocytopenia. So as you mentioned, it occur in maternal mak yang ada autoimmune disorder, saya SLE or ITP. So there are several factors that will impact the severity of the thrombocytopenia of the neonates, which is if the mother has a history of maternal splenectomy, or mother platelet also less than 50,000 microliter and during the pregnancy, and also the history of previous sibling also had neonatal thrombocytopenia. So for investigation, of course, we need to do full blood count to look for thrombocytopenia. Also, patient also can present with other blood disorder like leukopenia or anemia in certain diseases. Also, we need to do blood culture and sensitivity for both mother and neonates because we want to look the mother infection that can be and also neonates, which can lead to sepsis, and sepsis ultimately will lead to the IC. So we need to do peripheral smear. So if you do peripheral smear and look for platelet, if the platelet larger, it indicate that destructive or consumptive cause of thrombocytopenia. If platelet normal or small, it may indicate a decreased platelet synthesis. We also need to do coagulation study. We show high dimer and low fibrinogen level in patients with disseminated intravascular coagulation. As mentioned, we need to do maternal antiplatelet ALO antibody and parenteral and fetal platelet antigen genotype. This is for neonatal alloimmune thrombocytopenia. So important imaging, we need to do cranial ultrasound if we suspect the baby has intracranial hemorrhage. Genetic screening and torch screening. And also we need if it's indicated, we need to do bone marrow biopsy if suspect myelosuppression or any like leukemia. Next. So as for management, so this is the algorithm to manage patient with neonate with thrombocytopenia. So of course, first we need history and physical examination. And also after doing investigation, we look whether the baby has mild to moderate thrombocytopenia or severe thrombocytopenia. So if the patient is stable, and then if they moderate, we repeat platelet count at the age 2 or 3 days, and then at age of 5 to 6 days. Then if stable, we consider maternal antiplatelet antibody testing. And then if decreasing, we need to monitor the platelet count. If it keeps decreasing or become platelet count becomes severe, we need to do the procedure algorithm for severe thrombocytopenia punya management. So so patient with severe thrombocytopenia, we need to do night punya testing for the neonatal alloimmune thrombocytopenia and baseline head ultrasound. We need to do ultrasound because we are afraid of intracranial hemorrhage. If there is no active bleeding or ICH, we also need to transfer platelet. And also if there is bleeding or ICH intracranial hemorrhage present, we also need to do platelet punya transfusion, but with higher amount compared to with no active bleeding or ICH. So if we think that patient need multiple platelet transfusion, we might consider IVIG infusion. I think that's all from me.
Is there any question to the presenter? Or Doctor, you want to add anything?
So, no, I think okay, can proceed. Proceed. Agreed saying that.
Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Shazwani. So I'll be the last presenter for today, and inshallah, I'll present to you about vitamin K deficiency bleeding, Vkdb. So it is also previously known as the hemorrhagic disease of newborn. Okay, so before we start, as an introduction, at birth, the plasma level of the vitamin K dependent coagulation factors, which are factor 2, factor 7, 9, and 10, and antithrombin are low and do not reach the adult range until approximately 6 months of age. Apart from that, the thrombin platelet function are also altered in the normal newborn. So all these will make the neonates more prone to get hemorrhagic complications and will be worse if there is presence of illness or other stresses such as infection. So just now, in neonatal thrombocytopenia, we talk about problem in the primary homeostasis, right? So in VKDB, we'll talk about the problem in the secondary homeostasis, which involve the coagulation factors. Okay, next. Okay, so the definition of VKDB, so there is spelling error there, sorry. So VKDB, the definition from Nelson Pediatric Textbook 21st edition, results from transient but severe deficiencies in the vitamin K dependent factors and is characterized by hemorrhage that is most frequently gastrointestinal, nasal, subgaleal, intracranial, or post-circumcision. Okay, next. So before we go to the disease, let's get to know more about vitamin K and the normal physiology of vitamin K. So vitamins are one of the essential molecules, which means our body aren't able to produce it, and thus we need to consume them in our diet. So vitamins can be divided into water soluble and fat soluble. So vitamin K is one of the fat soluble vitamins. So other fat soluble vitamins are vitamin A, D, and E. So where can you get this vitamin K? So the sources firstly can be from the green leafy vegetable. So in the vegetable, the vitamin K is vitamin K1, phylloquinone. Next, you can get it from by the synthesis of our gut flora. So that is vitamin K2, menaquinone. And the third source is vitamin K3, menadione, is a synthetic vitamin K. Okay, next. Okay, so how vitamin K is absorbed into our body and why is it important? So okay, I'll explain. So in order to get a good absorption, you need a nice juicy gut flora, great liver, a robust biliary system, marvelous pancreas, and also a magnificent small bowel for the absorption of vitamin K. So the dietary vitamin K that you eat, for example, the green leafy vegetable, it is actually protein bound and needs to be liberated or need to be separated by the proteolytic action of the pancreatic enzyme in the small intestine. Then the bile salt will solubilize the vitamin K into mixed cells for absorption into the enterocytes, where it is incorporated into the chylomicrons, thereby facilitating the absorption into the intestinal lymphatics and portal circulation for the transport to the liver. Then in the liver, the vitamin K will act as an active coenzyme for the activity of enzyme gamma glutamyl carboxylase, which involved in the process of gamma carboxylation for the activation of factor 2, 7, 9, and 10, which is the coagulation factor. Okay, so next. So what happens when you have deficiency of vitamin K? So it will affect the activation of these coagulation factors 7, 9, 10, and 2. So it will affect all those extrinsic, intrinsic, and even the common pathway. So in VKDB, the prothrombin time will be significantly prolonged because usually the extrinsic factor will suffer first. That's why the PT is much more prolonged than the APTT. The APTT will also be prolonged, and the thrombin will also prolong. However, in severe vitamin K deficiency, both PT and APTT will be equally prolonged. Next. Okay, for the classification of Vkdb, we can divide it into early onset, classic, and late onset. So in early onset, the bleeding usually develops within first 24 hours of life, and it is associated with maternal medication that block the vitamin K action. So in early onset, it is associated with intracranial hemorrhage in about 25% of the affected infants. Okay, for classic Vkdb, it usually develops between the second until seventh day of life. And this can be largely prevented by administration of vitamin K prophylaxis at birth. And the third classification, the late onset, usually develops between 3 weeks to 8 months of age. And this kind of bleeding also associated in high frequency of intracranial hemorrhage in affected infants. Next. So the causes of Vkdb in newborn, firstly, is because of sterile gut. Just now I have mentioned that one of the source of vitamin K is made by our normal gut flora. However, in newborn, their gut are sterile. This will further contribute to the deficiency of vitamin K. Nextly, is because administration of drugs to the mother, such as warfarin, antibiotics such as isoniazid or rifampin, anticonvulsants such as phenobarbital and phenytoin. So all these drugs can interfere with the vitamin K metabolism. Next is there is poor placental transfer of vitamin K. This can be evidenced by low level of phylloquinone in the umbilical cord. Okay, next cause is because of excessive antibiotic use. This can be in neonates who have been staying in the NICU for so long. For instance, if they have sepsis, so they will be on long-term antibiotics. So these chronic long-term antibiotic will actually destroy the normal flora and further contribute to the deficiency of the vitamin K. Next is when there is also low vitamin K in breast milk. Um, I know that it is good for us. We always encourage mother to give breast milk to their child, right? However, we must note that there are three components that are lacking in the breast milk, which are iron, vitamin D, and also vitamin K. So susceptible kids, newborns, can get vitamin K bleeding if they are exclusively breastfed with breast milk only. And next is when there is malabsorption of the fat. Based on the physiology just now, when there are any problems that occur in the biliary system, for example, if the neonates have neonatal hepatitis or biliary atresia, or in the pancreas, if they have cystic fibrosis, in cystic fibrosis, the neonates, there is cyst and also fibrosis inside the pancreas. So it does not mean that they doesn't have the secretion of the enzyme. However, it will secrete a thick secretion that will clog the duct of the pancreas. Thus, the pancreatic enzyme cannot be secreted into the intestine, and thus causes malabsorption of the vitamin K. And when you have problem in the small intestine, for example, if you have inflammatory bowel disease or short bowel syndrome, it also can cause malabsorption of the vitamin K. Okay, next. Okay, next for the clinical features. So in history, what you must ask when you suspect Vkdb in children, in neonates, you must ask from the mother about medications that they took. So I have mentioned several drugs that can affect the metabolism of the vitamin K. So you must ask if there is any intake of those drugs during pregnancy. And then for fetal history, you must ask whether at birth were the child given vitamin K prophylaxis, any prolonged use of antibiotics, and ask whether the child is exclusively being breastfed or any diarrhea that may indicate problem in the intestine, in the small intestine. Okay, and then for physical examination, you can look for cutaneous bleeding, cutaneous bruising, look for bleeding from the mucosal surface, and if the child has been circumcised, there can be post-circumcision bleeding or bleeding from the umbilical stump. And then you must also look for signs of intracranial hemorrhage. So the child can present it with standard symptoms such as vomiting or new seizure. Okay, next. Okay, so based on Nelson pediatrics textbook, these are some of the site of potential site of hemorrhage based on the each classification. So from in early onset, the hemorrhage tends to be cephalohematoma, subgaleal hemorrhage, intracranial, gastrointestinal, umbilicus, and intra-abdominal bleeding. In classic, there can be gastrointestinal, ear, nose, throat, mucosal bleeding, intracranial bleeding, post-circumcision, cutaneous, and injection site. And from late onset, can be intracranial, gastrointestinal, cutaneous, ear, nose, throat, mucosal, injection site, and thoracic bleeding. Okay, next. So these are some of the pictures of the bleeding. So in the class, the most common type of Vkdb is actually the classic one, which occurs usually from day 2 until day 7. That is why circumcision is not performed in the first few days of life. Nevertheless, in Islam, it is advised to perform circumcision at early age, as there are several hadith that support and even encourage parents to circumcise their son at 7 days old. This is because UTI are more likely to occur in boys under 6 months old. Thus, to reduce the risk factor, it is advised to do early circumcision. Okay, next. Okay, for the differential diagnosis, the when child come to you with bleeding, you may suspect the child may have the IVC if they have symptoms that suggest sepsis. Apart from that, you must also consider if there is any hepatobiliary disease, for example, neonatal hepatitis or biliary atresia that compromise the vitamin K metabolism. Neonatal thrombocytopenia, for example, alloimmune thrombocytopenia or maternal immune thrombocytopenia, hemophilia A, hemophilia B, which are X-linked recessive. So you need to ask about family history of bleeding, okay? I mean deep bleeding, usually in joint bleeding. Okay, and then any family history of von Willebrand disease, which is rare in Malaysia. Okay, so all these congenital coagulation disorder will usually not improve with the injection of vitamin K. Okay, next. Okay, for the investigations, firstly, you would want to look at the coagulation profile. So as I said earlier, there will be prolonged PT, prolonged increased INR, prolonged APTT. However, the platelets and the fibrinogen will be normal because Vkdb only affects the secondary homeostasis. Okay, the coagulation factors are compromised. Next, you can look at the levels of protein induced in vitamin K absence, PIVKA2. Okay, so PIVKA are they are more sensitive than the prothrombin time in detecting vitamin K deficiency, and it may be helpful in monitoring patients with diseases predisposing to the vitamin K deficiency. Okay, and then you can also look at the plasma level of factor 2, 7, 9, and 10. Okay, the coagulation factors that are affected by the vitamin K. Okay, next. Other than the lab investigation, you can also do urgent neuroimaging. For infants with abnormal result of neurologic symptoms, you would want to detect for any brain hemorrhage. So what are the okay, so you would want to do a cranial ultrasound because it is fast to do the cranial ultrasound rather than to wait for the MRI or CT scan. So, however, cranial ultrasound, they are good to look for intraventricular hemorrhage because usually you will you will put the probe at the anterior fontanelle. However, it is more difficult to view if there's any subarachnoid or subdural hemorrhage from a cranial ultrasound. So you want to do a brain CT scan, or the best is to do MRI brain lah, to look for any parenchymal bleeding and also to look at if there's any tissue destruction. Next, you can also do full blood count, and in Vkdb, the platelet count would be normal. Okay, next. Okay, next. Okay, for the management, so I divided it into prevention and treatment. So in prevention, firstly, you must avoid the high risk medication that can compromise the vitamin K absorption. And then you also must ensure that your child receive the vitamin K prophylaxis at birth, which is 1 milligram given intramuscularly. Usually, they will give it in the labor room, okay, given to all baby. And then for treatment, if the baby, the neonate had already developed vitamin K deficiency bleeding, you can treat them with a slow IV infusion of 1 to 5 milligram of vitamin K1 or transfusion of fresh frozen plasma or whole blood, or if there's underlying cause such as biliary atresia or cystic fibrosis, of course you need to treat the underlying cause first. Okay, next. Okay, that's all. These are my references. Okay, next. Any question from the floor? Or
I've
Doctor,
got a
would you like?
question.
Yes.
How to differentiate the bleeding disorders lah, macam von Willebrand and vitamin K semua ni, clinically besides asking family history and in lab investigation, is there any way?
Um, tak ada kot. I think of course you need to do investigation because Vkdb and yang hemophilia von Willebrand tu dia kan involve the secondary hemostasis kan, in which means dia punya clinical features are deep bleeding compared to primary hemostasis. You punya bleeding tu akan macam more superficial. So
Maksudnya more mucocutaneous ke?
yes.
Tapi sebab von Willebrand pun mucocutaneous juga, sebab tu tanya.
Okay. So kalau von Willebrand tu you need to check for the factor berapa dia? Factor 9 von Willebrand factor tu lah sendiri. Okay.
Okay, thank you.
Doctor, would you like to add anything? Doctor?
Sorry. My line here is a bit patchy lah. Sudah ada ke dah tak ada? Pening. Okay. So just few things that I need to add. Vitamin K deficiency issue ni, there's one issue that you will be facing later on. If you notice, sekarang ni dah makin ramai geng-geng anti-vaksin kan? Betul tak? The thing is, what I have seen is, this anti-vaksin ni, dia akan refuse vaccination satu, but they will people datang deliver, refuse any vaccination in vitamin K for my baby. Despite reason, because of refusal to receive vitamin K after birth. So this is one thing that you guys will see more when you guys become doctors later on. Menarik tak? So this is a problem that you will see lah. Okay, alright. Any question? Any question to the presenter?
Doktor, tadi rasanya macam sekat-sekat. Boleh ulang balik tak?
Ya tak? Alamak, line ni, my line memang tak apa bagus. Hello?
Yes, doktor. Cuba doktor cakap.
Hello?
Hello, yes.
Okay.
Yeah, we can hear you
Any
clearly.
question? Any question? Yes.
Doktor, just now yang you cakap, doktor cakap pasal yang there are parents yang refuse to receive vitamin K tu tak clear sangat sebab tu sekat-sekat. Can you repeat that again, please?
Dengar Wi-Fi cannot get. Macam mana? Sorry. Again. I cannot hear you.
Just now you mentioned
Yeah.
about there are parents yang refuse to receive vitamin K tu kan, yang tu tersekat-sekat time doktor cakap, so boleh tak doktor ulang sekali lagi?
Okay. If I were to repeat, so the issue is there are increasing number of basically anti-vaccination group, naturopathies yang semua nak natural, everything nak natural kan. Makan tak nak pula natural kan, tapi semua benda nak natural. So it's okay to get natural things, but then you need to think lah. So there are people now against vaccination. Despite all this pandemic now, they are against vaccination. But one thing is, many of them, when the ones that I saw, they not just refuse vaccination, they even refuse vitamin K. Dia datang bawa surat terus, kata I refuse my baby to receive any type of vaccination, including vitamin K. They thought vitamin K is a vaccine. Despite it acts differently, it is not a vaccine. So the issue is, because of this, we are seeing more babies with vitamin K deficiencies and causing bleeding and so on and so forth, which I've seen intravesical hemorrhage because of refusal to receive vitamin K. So the cases are increasing. So the issue is, you guys will see more of this later on when you guys become doctors, because the number of vaccine refusal is actually increasing. So this is one thing that we do need to think about. But the problem is, all these anti-vaccine groups, they have fixed false beliefs. So it doesn't really matter how much facts that you give them, how much evidence that you give. They have a fixed belief that the only people that can convince them are ustaz. If you're ustaz, if you're ulama, then they'll believe you. If you're a doctor, then you are agents of Israel or something. Kan? So that's the difficulty in handling this type of people, because they have fixed false belief. Okay, any question?
Doctor, I have a question regarding the vitamin K that we give as prophylaxis to every newborn too. How to convince the parents about the content or the substance used in that vitamin tu are all halal and safe for their baby lah, tak macam vaccine.
No, just tell them. Just it's easy. Just tell them. The first thing is al aslu fil asya al ibaha. The original ruling, hukum asal for everything is al ibaha, is permissible. Al aslu fil manafi' al ibaha. Hukum asal bagi everything yang give benefits is al ibaha, mubah, is permissible. The only thing yang begins with haram is al aslu fil ibadah al mamnu. So hukum asal bagi anything related to prayers in ibadah, it is al-mamnu, it is haram. Kan? So there's only few things that are not undergone slaughter and so on and so forth. There's not many. So what you can tell them is first, for vitamin K, there's nothing animal in it. It's not animal based. There shouldn't be an issue. There's no alcohol in it. So there's no issue in it. And we can also say, like for vaccine, I don't know, I should have a common lecture on vaccination actually. I'll talk in a length about vaccination issues. All vaccines that are given by Ministry of Health in Malaysia are halal certified. That's it. There's no issue about haram and so on and so forth. Okay. Anything else?
Thank you, Doctor.
Okay. Again, I would like to apologize for the shortcomings because there's so many ill babies that I need to handle. It's been running around. I actually, your class is, I'm attending a meeting with UNHCR team. So that's the thing. There's so many things going on at the same time. But okay, all right. So I pray the best for you all. Nanti remind me, give me the names of the presenter and the topic that you presented. Then I'll give the marks to Sister Farah. Okay.
Okay,
That's it.
insyaAllah. Right.
Okay.
Thank you, Doctor.
Thank you,
Okay, Assalamualaikum.
Doctor. Salam.
Thank you, Doctor.